IHPI Research Center. We're very fortunate to have as our speaker Dr. Sachin Kheterpal joining us today. Dr. Kheterpal is an associate professor of anesthesiology and also associate dean for research information technology at the University of Michigan Medical School. He received his bachelor's degree, his M.D. and his M.B.A. all from the University of Michigan. Dr. Kheterpal's career has been focused on the novel use of IT and electronic health records for patient care, quality improvement, and research. He is recognized as a national leader in perioperative large dataset clinical research and has published numerous articles, editorials, and book chapters regarding intraoperative management and long-term postoperative outcomes. Using innovative techniques to integrate administrative, EHR, and registry data from across institutions, he leads the Multicenter Perioperative Outcomes Group, a research and quality improvement consortium with more than 40 anesthesiology and surgical departments. In his role as Associate Dean for Research Information Technology, Dr. Kheterpal is responsible for establishing the vision and strategy to effectively use IT to advance the research mission at U of M. He is also a member of the advisory panel for the NIH Precision Medicine Initiative Cohort Program. His talk today is titled Precision Health at the University of Michigan, Building the Platform our Patients Need. After the talk, there will be a short period of time for Q&A and then some refreshments in the lobby. So please join me in welcoming Dr. Kheterpal.
That intro sounds really long. That intro sounds really long that way. Jeez. Thank you. I appreciate you showing up on a Thursday afternoon for this. We'll try and do a 30, 40-minute version of this and leave more time for Q&A if possible. I've got my senior resident from my intern year in the crowd here, Akbar, so I'll have to try and be honest with this. All right. So I'm actually here on behalf of a couple different folks. Gonzalo Abscesis, who's in the School of Public Health. The guy's literally a genius. He's in the Institute of Medicine at age like 32, 33, doing amazing statistical genetics work. Eric Mikkelsen, who's the Associate Vice President for Advanced Research Computing, amazing scientist who's focusing now on making it easier for other people to do science. So everything you see here is based upon a ton of people's work, but I'm speaking on behalf of all of us. So a little bit is kind of expectation setting of what this thing is that we're talking about. I think this is what we deliver on a routine basis, is we deliver somewhat personalized care. So if I've got a 75-year-old in front of me versus an 18-year-old, I deliver an anesthetic slightly differently. That's on Wednesdays, I'm an anesthesiologist. So yesterday, I delivered care differently to my 75-year-old patients and my 18-year-old patients. I maybe understand their clinical record a little bit so I know whether they're sick or healthy. We've started doing with precision medicine is incorporating new data streams into that decision. So when you have cancer, we're now sequencing that tumor commonly. We're commonly looking at your chromosome analysis to say, let's take that clinical phenotype and add in some additional biologic phenotypes that we haven't historically that go beyond a CBC or a hematocrit, which are also biological concepts. What we're trying to propose, we build as an initiative at the University of Michigan, is we call precision health as opposed to precision medicine, which is to incorporate data streams that we historically haven't thought of as effectively. So, we should learn about that patient's socioeconomic status. We should learn about how they eat, whether they smoke or not, when was the last time they smoked, where they live, what are their environmental exposures. What we've learned is that from an actionable data perspective, your zip code is probably more important than your genetic code, is the reality of it. But how do we make sure we're not doing an either or? How do we make sure that the social scientists who understand the zip code and the biochemical scientists who understand genetic code aren't sitting there fighting over dollars or over platforms to pick which one's more important? How are we making sure we add both of those together? And it's about bringing those data streams together and building a platform that allows either of those data streams and hopefully the combination of them to be informing the choices that we offer our participants. And explicitly, we're not talking about just medicine after you're in a disease state. How do you prevent getting sick? And if you happen to have gotten sick, how do we manage that in the different trajectories that are possible? Fundamentally, we think there's three phases to this. There's what we call precision discovery, which means different things to different people. So it's the basic science of what you do in your lab. Your lab might be an actual biology lab where you're building new chemicals or you're identifying new compounds. Your lab might be my lab, which is a coffee shop with a laptop. My chair once had a picture of how we do research at U of M, and he actually did the cost of his basic science lab versus my lab, and he said laptop $2,000, $3 a cappuccino times 2 a day, that's the rent for his office space. Wherever your lab is, and it might be how you ask a participant whether or not they're depressed, the hard work that goes into understanding patient-reported outcomes, that's basic science, that's discovery. We want to take that discovery, it might be a machine learning algorithm, it might be a new AI technique, take those discoveries and decrease the friction of turning that into something you can actually evaluate. There's so many great ideas that never make it out of that basic science lab because you publish it and then it sits there and there's no way to go actually test it on thousands of participants and community members here in Ann Arbor and outside Ann Arbor as well. And so it's about validating those precision discoveries and actually trying to see at the University of Michigan Healthcare Enterprise, which sees 2 million patients per year, working with partner institutions outside Ann Arbor, let's validate some of those discoveries and see if they actually work. And some of those discoveries, when they actually work, it's our job as a public university to go make sure you don't have to come to Ann Arbor to get precision health. What are we doing to make Alpena a safer place to live? When I'm driving from here to Chicago for a trip and I get into a car accident, what am I doing on a daily basis to make sure that my experience when I get in that accident in Kalamazoo is better? So it's about precision health, implementing that and disseminating that far beyond. And certainly IHPI has been the inspiration for a big part of this. The definition of success being going beyond the borders of our wholly owned health system and making sure that we're disseminating it, but also making changes where necessary to enable dissemination. So if that means talking to our payers to get them to compensate precision health as opposed to imprecise health, if that means making policy changes when it comes to privacy or access to genetic data or access to socioeconomic data, what are the policy changes that are necessary? And the basic concept being that this is not a funnel anymore. It used to be. So when I gave this pitch a year ago, we had all these discoveries, a few treatments, and then a few precision health. We've learned this is actually a virtuous circle. Precision health taught us about the opioid misuse crisis, and it is driving discovery opportunities. So we now have scientists out there trying to figure out what are the genetic markers related to addiction and being more susceptible to being a chronic opioid user. We now have basic scientists figuring out how do I make pills that actually stop having an opioid effect 30 days later. That's precision health driving precision discovery as opposed to just a funnel in a one-way stream. What are the data types we need to make this happen? Certainly we've always, in our healthcare system, thought of the medical phenotype. We've started thinking about the genetics phenotype. All these other arrows are arrows that to be blunt, when I give this talk at IHPI, I don't have to convince anybody of this, but when I give this talk to different places, they say, so this didn't used to say this until 2 days ago. When I gave this talk to a basic science crowd, they said, what, it's just genetics? So like literally yesterday morning, I added a biology thing in here so it has a cell now. So when I go to basic science crowds, they tell me there's not enough basic science. When I go to medical crowds, they tell me there's not enough clinical science. Usually when I go to a policy crowd, as it turns out, this policy crowd gets it that the concept that our policymakers are involved in precision health is a novel concept. This is not how a lot of people are thinking. But these other data streams, behavior, lifestyle, the environment, understanding the patient's social environment, when people ask me what's the hardest thing in all this, I actually say, we think we have the ways to get all of these arrows, but this arrow is about the family around you. How are we going to learn about the family around you? I can put an iPhone on you, but how do I figure out if you've got a good support structure or not? That's actually really hard. So the social environment around you is going to be a really tough nut to crack, and people like IHPI and ISR are really going to help us do that. We think these are all the arrows that we have to glean that inform what a patient's experiencing, and then we have to have these data streams present to actually understand the patient's experience. So what is this thing we call the Precision Health Initiative at U of M? It is 5 specific funded work streams. We've got funding for the next 3 to 5 years, depends on who you ask and how you ask them, like everything at U of M. 5 specific budgeted work streams with faculty leaders and staff leaders. They're not in any particular order. Cohort development, I also call community development sometimes. It's a funded work stream around sustaining the Michigan Genomics Initiative, which we've been doing at U of M for the last few years. I'll get into that in just a moment. But expanding it to include many more novel data types, both at the biological level, so digging into different ways of interacting with the genome, the epigenome, the other biologics, RNA in there, but also other data types that are outside biology, understanding that patient's geolocation data, so we understand how far are they from the nearest liquor store versus how far are they from the nearest grocery store with fresh fruit. That might be more important than their ApoE lipoprotein polymorphism, as it turns out, to what their cholesterol turns out to be. Very importantly, we have to leave the confines of the University of Michigan and Ann Arbor to make progress here. We have to go to places that don't look like this room and don't look like our patient population to learn the biology and to learn the socioeconomic status and ethnic and racial backgrounds that go into health outcomes. We've already started working on mobile apps for those participants, doing some alpha work in that area so we can actually understand steps, activity, geolocation data, heart rate. Data and analytics is actually one of the most exciting things, and each of these is a faculty leader. This one's been officially announced. Brahmaji Nalamathu, who leads the Data Methods Hub, working with Jenna Ween from the College of Engineering, are leading the data and analytics workstream. As you can imagine, we're generating petabytes of data out of the cohort development workstream already. How do you analyze that? Do you actually have to have each researcher build a new server underneath their desk? Do they all have to go get an Amazon Web Services contract? Are they writing the tools themselves every single time to inform the data with the geolocation data? So what Brahmaji and Jen are leading with a bunch of staff is going to be integrating all these different data types onto a private cloud environment that'll probably be Glovebox++, but working with public cloud providers so that when that private cloud doesn't have enough horsepower, we can flex up to the public cloud to interact with it. We believe that the data that we're creating here and that the data that we're making accessible, which goes beyond the 50,000 patients in MGI, includes all the patients in the health system, that data is going to serve as a watering hole to bring different researchers together. In many situations, though, as it turns out, that data isn't sufficient. When it's not, the tools that we're developing, the environment that we're building will be the other watering hole. So you don't have to be using MGI or U of M Health System data in order to be able to be part of the precision health workstream. You can bring your data into that environment and into these analytical tools. And people in this room, like Patrick Brady, are fundamental to helping us actually make this happen. What you've done at IHPI with the Data and Methods Hub is really a model for what we're trying to do and scale out of precision health. This is going to involve making it so that you don't have to develop your own machine learning algorithms and tools every single time. It'll come preloaded with Weka and Docker and the container software on there, so you can be on your local private cloud or go to public cloud. Every now and then, we'll actually find something that works. As anybody who does research realizes that you spend a lot of time publishing stuff that doesn't work. Every now and then, something does work. So how do I go actually do it now? Is that the end of my pathway? And when it comes to implementation science, I'm preaching to the choir in this setting. How do we actually go back to the health system? And I fundamentally believe this is not something we can outsource to a for-profit entity like Epic. We cannot depend on Epic, which sells the exact same software to every single hospital around us, to be our implementation differentiator. It's got to be the implementation scientists at U of M. We have to write software on top of our operational entity that actually lets us modify the interactions that provider is having with that patient. New visualizations, data streams that are outside of electronic health record, all are things that we can't get out of Epic. Epic is doing very important work because the effector arm of that decision is inside Epic. We're so lucky we don't have to worry about how to order the right thing, but figuring out what the right thing is, that's what we think we have to put some significant dollars into, building those decision support environments and tools so that when Akbar comes up with a new way to decide who needs hepatitis C treatment, when he has that right idea, he's got this huge barrier to entry to go through 18 committees at U of M to actually get that put into a BPA. Our job is to get rid of those 17 committees and maybe only have one. You gotta have one. We'll get down to one committee and a software platform that's written using standards so that he has an idea, we have some consented patients or consented providers. Let's make his barrier to entry from going from precision discovery to precision treatment as small as possible. And certainly, the policy and dissemination work. Now we figured out the right answer. How do we get it rolled out using the vehicle of the CQIs, using the vehicle of all of our relationships throughout the state of Michigan and nationally as well? Certainly it takes real dollars to train people to do this, so we need students that are versed in how to be precision health scientists. We need more software developers. We need more genetic counselors. We need more people that can actually be part of this science machine, but we also need to be educating our providers on how to be precision health doctors and nurses and PAs. How do you actually have a conversation where instead of thinking that precision health is about a better right answer, it's about a more informed set of transparent choices? I'll use Brahmaji's Google Maps metaphor. He talks about how you take a left turn and a right turn. I take it one step further to say, if I'm going from here to home, the goal of precision health is to create the education visualizations to actually be able to communicate to the patient. Here are 3 pathways you can take from where you are right now in your healthcare journey. We recommend this one because 10,000 patients took it and this was their healthcare outcome. We've got 2,000 patients who took this other route that involved not having the surgery, and here's how they did. And there's 3,000 patients who decided to have this other option and they didn't do as well. These 15,000 patients all look kind of like you, have your similar age, your similar disease burden. These are the choices. Now let's make a decision. That takes real education for a different interaction with the patient as opposed to saying, get a cath, don't get a cath, get a stent, or we just get your blood pressure med now, like right away. All of these have embedded in them a lot of research dollars because there's basic science discovering how to do each of these things. On top of this, we're doing some incremental dollar allocation to one specific use case that I'll mention in just a moment. 4 use cases. So what we're talking about here is we're building a platform, right? But you can do a lot of build it and they don't come. I've done that before. I hopefully won't do it again. So we wanted to make sure that we were actually solving real problems and real researchers and real implementers found it of value. So we talked to cancer center researchers, mental health researchers, folks involved in cardiovascular disease, diabetes, and folks involved in the opioid misuse crisis. And we said, will this platform inform science in all these areas in 2 ways, both in creating the data sets they need, but also in creating the analytical environments they would want to use, even if they're not using the data set that we have to offer. One of the ones that President Schlissel was most excited about because it tested us in the most unique way. It's very comfortable and necessary to advance cancer care. It's still killing hundreds of thousands of people. We should invest in it. But in a world of fixed resources, we said, what is the place we've invested in the least, yet is continuing to have major public health impact? And that was the opioid misuse crisis. As everybody in this room knows, they've already gotten this talk like a few weeks ago from Chad, right? So 6 to 15% of people who've never had a Vicodin or an opiate before their surgery or before their wisdom tooth extraction, Mike gave this lecture too, 6 months later, they're on it. We think this is the most common complication after surgery, whether it's a minor surgery or a major surgery. That's unbelievable, scares the bejesus out of everybody I say this number to. I've yet to state that number and not have people go, oh, especially people outside healthcare, corporate relationships, they go, wow, that's really scary, and it's real. 70% of the opioids sitting in your closets that you were prescribed wind up going unused. So what we really believe is we need an opioid prescribing strategy that is a precision prescribing strategy as one of the things to address the opioid misuse crisis. Not the only thing. There's a ton of treatment effort that needs to happen, but one place we're going to allocate some incremental dollars on top of the platform is precision opioid prescribing, and Chad Brumman is leading that initiative, as you might guess. And the end goal is that the number of pills is informed by our risk of abuse, evaluated by our risk of diversion, who's at the house with you, what have you done in the past, what is your environment, what do you need, and it's actually informed by data about that individual, but informed by populations of data about the hundreds of thousands of patients that we've prescribed medications to already. A couple examples of specific things that are already happening that we're going to be expanding with Precision Health with new dollars to make them more usable and more generalizable. So has anybody in here used the MGI dataset? This is not really an MGI kind of crowd, but there might be 1 or 2 people in here. All right. Liars, Mike did, he barely raised his hand, so I know somebody has. So every day, about 40 to 70 patients walk through the perioperative process and through the minor or major procedures process. Anybody where an anesthesiologist is involved and is poking you for an IV or for a blood draw, we ask them, hey, could we take some of that blood that we're drawing and send it to the central biorepository led by Vicky and do some genotyping on that and combine it with the EHR and some cost data and some prescription data? And 72% of the people say yes, which is unheard of for a multi-use biobank. We're integrating all of the EHR data. The fun thing is we now have U of M cost data integrated with it. So it's one of the unique biobanks that has your genotype and your costs. That's not really that common in the US. It also includes non-EHR things like pain, mood, function. And we're integrating other data sources into it right now actively. And the end result is we now have researchers on the biomedical side using this to figure out what are some of the predictors of having aortic valve disease, of having atrial fibrillation, things that are commonly being researched. As it turns out, 50,000 patients is interesting, but it's not enough. It's often hypothesis generating, and there's other publicly available data sets. When you find the genetic relationship, you can dig into it further with a publicly available data set. But you still need to have an environment where you can do something very important, which is you can go back to individuals. There is a UK biobank, which has 500,000 patients in it, publicly available. It has no electronic health record data because they don't do that electronic health record thing in Europe, as it turns out. More importantly, if you find a couple participants of interest, you can't go get more data about them. You can't say, can I go talk to your family and your siblings to see if they have these problems? These patients are consented to actually be able to be recontacted, and they were consented to let us connect to whatever other data sources we find, which is a much more interesting reusable data source. It's growing by 10,000 participants per year. We're going to keep growing it and informing it. We're building upon the data science initiative, which many of you already know about. So Eric Mickelson obviously is a key leader in advanced research computing. So a lot of the work that goes into building an analytical platform has already been handled by other initiatives. We're going to make it specific to the precision health use case scenario, and in the process break down some barriers that all health research involves. You know, we're on these phone calls and committee meetings beating down compliance and HIPAA and all these different things that you deal with every single day, so that hopefully those hurdles that everybody's dealing with individually, we handle them up front and you don't have to keeping them over and over again. Another example that I think I've given this talk on Data Direct before here to this group. So we're actually evolving Data Direct. You know, we're now up to 3 million patients. We've got more and more high performance versions of it. So we spent the last couple of months making this thing work a little bit faster. It used to take 10, 20, 30 minutes sometimes to get a result. Now it takes a couple minutes. Our next step is to take this and put it on the advanced research computing platform on campus. Imagine a Hadoop cluster underneath this. We're trying to get this from minutes down to maybe seconds is one of our goals. So take this to achieve two things. One, make it faster. But as it turns out, if you're in the College of Engineering, the simple act of getting a level 2 login is like this Mount Everest that people just are not willing to climb. So getting this put on campus without needing a level 2 login and exposing it to all of our researchers there is a huge win. I did not think that would be a huge win. As it turns out, it will be. They're very excited about something as simple as that. It takes some real technical work on our part to move this platform over there, and we're going to do that as well. This is something that Gonzalo leads, Top Med. Brahmaji mentioned this to me. You know, when you go to places, anybody doing genetics, the guy is like a rock star, literally. So he happens to be curating 98,000 genomes. That's like kind of his thing. And building the reusable tools that people from around the world use to do genetic analyses. And what he has learned, and we're going to be using inside Precision Health, is one very important concept is you can use one of those 98,000 genomes that he's curated across 25 different NIH studies, or you bring your own genome. And you can take your genome data and connect it to those 98,000 genomes he already has. And that skill set of how to take third-party data that is the researcher's data and connect it to a publicly available data set in this little watering hole is a really important skill set. Gonzalo's done that many, many times, and we'll be doing that same thing for Precision Health. So you can take your curated data regarding the population you have from Henry Ford Health System, because that's where your R01 was funded through, and now compare them to all the U of M patients. Bringing your own data into this enclave is a very important concept, and Top Med is an example of that. One other thing we've started doing, some of the people in the crowd that have helped make this happen, is we've started rolling, we're at not the rolling out stage. It's under IRB review now, so the application's ready to go. It's called Prosper, but we now have a consent, using ResearchKit, the ability to actually consent a participant through the iPhone app without having a research coordinator. It's within my perioperative group, the MPA group. Prosper is what it's called, the prospective study of perioperative experience and recovery. A lot of those patients are already getting MGI data on. We're now going to be collecting things that you're used to collecting. So NIH-based promise measures, World Health Organization disability scale, things that we know are validated instrument across thousands of participants. Now let's compare them in the U of M population. This is a platform we're going to test to see how well this could scale up to precision health possibly. There's a world where people opt in and select themselves to join as opposed to getting a research coordinator. People who actually download the app as opposed to having a research coordinator giving them the app. Let's see what the capture rates are on that. And the fun thing about this is we can automatically behind the scenes get their daily steps, how many flights of stairs they traveled, their Nike fuel points, their exercise time, their sleep cycle, all the stuff you're getting out of a Fitbit, you can also get out of the app. And as it turns out, we're also getting the geolocation data to see how often they're leaving their house, because that might be the definition of recovery and quality of life. My going in hypothesis is that these surveys will eventually be replaced by passive data. Right now we bludgeon our patients with PROs. That's progress compared to 10 years ago. 10 years ago we didn't even ask them. Now we're asking them too much probably. And there's probably a place in between where we passively ask them the right things that we can't collect in other ways, and the rest we go ahead. So our hypothesis is that a lot of passive data will probably replace some of those active surveys that we're bludgeoning them with. So is this a research project? Yes. We're going to create new knowledge. We're going to help people create new knowledge, write papers, get R01s, get DoD grants. That's the purpose of this, is to create science and create fundable science and make you more competitive for science dollars. Imagine if in your next grant, you have a grant section that says, by the way, I already have access to 2 million patients, 50,000 of them I have genotypes, 100,000 of them I've got cost data for Medicare, links to the electronic health record, and I have an analytical platform. That I get for free. On top of it, NIH, DoD, could you give me a couple faculty and a couple of research assistants? That's a much more competitive grant application than I'm going to go dig my own well and create my own cohort and create my own Amazon Web Service instance. Is it an education initiative? Absolutely. We need to attract, retain, and train the next generation of scientists. And there is a service component to this. Compared to a Stanford or a Partners, it has to impact the health and well-being of people in the state of Michigan. That's in the Constitution. That's why University of Michigan exists. So some of this, people have to be able to say 5 years from now, hey, I'm in Washington County. Am I better off now than I was 5 years ago before they made this investment in this thing? We have to be able to say yes to that. We've talked about the cohort development piece a little bit. So what are we actually going to be doing with it? We're actually already recruiting 7,000 participants. One of the key goals is to go outside the perioperative process. We know we have to go to clinics that we aren't in right now. As it turns out, the 50,000 participants we have are amazingly representative. We've got people that are 18 years old and tore their ACL during a football game, and we've got 75-year-olds getting heart transplants. So when a researcher comes in and says, I don't know if this will be of interest to me, it almost always is of interest to them. Even in the rare disease setting, there's usually 50 to 100 people with a rare disease in here. But we need to go out to clinics. So there's actually going to be a competitive grant process where we're going to say, we'll pay for the banking and for the genotyping. If you pay for the upfront recruiting, we'll pay for the rest of it and you get the data. So we're actually going to have a challenge grant announced around clinic-based recruitment using this platform. We're already doing Illumina chip extraction. We're working on this iOS application, the geofencing. Our stretch activities is to keep that 10,000 going, plus get 1,500 patients in a clinic setting. Our stretch goal is to expand to Mott Children's Hospital. As you can imagine, that's got its own consent issues, biosampling issues, but it's really cool to have a parent in MGI and their child in MGI and watch them for the next 10 years and see how their health evolves over time. And we certainly know we have to do additional biospecimen processing. We have to be doing something more than just DNA genotyping. We may be doing next generation sequencing. Maybe we need to get different biosamples. That's what's at play and what we're still figuring out. On the data and analytics side, so thanks to the hard work by folks on campus, we now have a business associates agreement signed with Amazon, Microsoft, and Google. That doesn't mean you can put PHI on there yet, unfortunately, because as you can imagine, all that means is by accident you can release about 1 million patients' data by putting it on there. So we've really made things a little bit worse before we make them better. And so what we're going to do to make them better is work with people at IHPI that have done this with Glovebox to say, what is the process by which a scientific facilitator, a scientific concierge, helps you quickly instantiate an AWS account, quickly instantiate an Azure account, and bring your data into that so that you securely, without letting other people see it, can put health system data on there and use the existing tools. There's a fair amount of work on being able to do this in a private cloud environment as well. That's what Eric's working on. As it turns out, public cloud is great. It just happens to be 3 to 10 times more expensive than computing on site. So how do we make sure we use the public environment, kind of like the Ubers, right? If I only used an Uber for all of my driving for an entire year, it would be more expensive than owning a car, as it turns out. However, the Uber is really nice if I just need to go somewhere. My excess capacity, I Uber when I'm out of town. I don't feel like buying a car in San Francisco for the week I'm there. So as it turns out, that's where public compute might make sense as well. Let's use private cloud for our known capacity, get 80-90% utilization on that thing, and then every now and then we've got a super high performance computing need that flexes up. That's where we go to public compute. The issue there is, how do I make sure I don't have to make that researcher completely rewrite everything they're doing in order to go from private to public? That's literally what we're working on, is how do I make these containerized and using things like Docker software, so that if I've got my little VM that works here locally, how do I take that virtual machine and then put it up in the cloud at the same time? And there's technologies available to let us do that, and that's some of the exciting stuff. And when I get there, I've got the tools I want. As it turns out, the more proprietary the tool is with the higher license, the less likely we'll be able to offer it to you. However, people tend to be heading in the right direction. People are using R more often than they're using SAS in a lot of settings now. If you're a public algorithm, public software person, open source software person, we think you're going to love this environment, because that's stuff that we can offer on Azure and AWS relatively easily. The more license-heavy SaaS type of thing, the more difficult it will be. But we're going to see some evolution there, so that the tools you want are already on there. So what is this thing from a structure perspective? So there are 4 founding entities. So administratively, this is housed within Dr. Runge's EVPMA office. There were lots of places we could have put it. We could have put it inside Jack Hu's Office of Research. We could have put it somewhere else. Because this is research and education and service, it's sitting inside the EVPMA's office. The provost of the university, Martin Filbert, the most recent dean of the School of Public Health, combined with 3 other schools, the College of Engineering, School of Public Health, and School of Medicine are the 4 founding funding entities of this thing. We're now building a faculty advisory committee. The executive committee, which is comprised of those 4 founding schools and the provost, is reviewing that faculty advisory committee. We're going to have a national advisory board. What we've got right now is somewhere between 35, it depends how you add the numbers up, somewhere between 35 and $45 million over the next 3 years committed to those 5 work streams. That's committed. And then we got a verbal commitment that years 4 through 6, whatever we can bring in externally, they'll match. So if we bring in $10 million externally per year, they'll give $10 million. We'll see what happens with that. Verbal financial commitments are not that effective. So we'll see where we go. But our hope is that we can at least count on something other than a cliff at the end of it. But very explicitly, it's our job to create tools that make you more fundable so that 3 years from now we can say, here's the dollars we're bringing in, here's the indirects we're bringing in, here's the staff and faculty we've been able to recruit and retain. So if this isn't of value to you, we need to change what we're doing. And I will stop there and open up for questions. Thank you. Anything I lied about, Raji or Rachel? I always have my occasionally I have fictional writing in my words. Mike.
Sachin, I'll ask a question. So for
kind of a simple surgeon, if you kind of have a problem, my patients, I have this idea, how would this go down? Because for someone who isn't data savvy, this is very intimidating. So how would this go down? Let's just throw it out there. Hepatitis C after recurrent liver transplant seems like it's a bad thing. I want to potentially write a R01 on this, and I don't even know what the questions would be. How is there like a consult service where we could kind of talk to someone who understands what the hell R even is and things like that? So.
Absolutely. Excellent question. And so that's actually our analytics work stream and our education work stream. So the entire thing we've learned is that you can build software, and eventually if you build it well enough, it can become very self-serve, but the process to go from idea to execution requires something. So there's budgeted people in this that we call them concierge, but we decided no one would apply for that job. It sounds like you're a servant. So it's not a concierge. Those of you who will apply for the job called scientific facilitator. And that's truly what they are. Their job is to have a lot of fun working with really bright minds to take those bright ideas and say, okay, here's data. Let me sit down with you and go through Data Direct or Top Med and say, here's how many participants we have that have had a liver transplant and now have hepatitis C in this data set. Oh, and now we're going to flex and also show you how many people inside Optum possibly have had the exact same kind of diagnosis. Here's the burden of disease. Okay, now with that data, here is what of these data elements do you want? They'll work with you to write the query, pull the data down in a self-serve way where possible, and help instantiate an AWS, Amazon Web Services instance, and tell you what AWS stands for and whether or not you need it. And the number one thing is when you get there, the tools you need to work with it. So right now, machine learning is one of 2 things. It's either like experts like Akbar or Michael or Ramaji, or just total amateurs like me who like read about it, do a Coursera course on it, and we just start playing with it, right? It's somewhere in between. It's not a way of life for us. And these scientific facilitators are going to set it up so that the tools are on there. So you say, here's my covariates, here's my exposure variables, here's my outcome. How do I set up a SVM for this? How do I set up a ensemble analysis? That's exactly what their job is going to be. As you can imagine, those people will be in high demand. So what we have to figure out, is that a recharge rate based thing so we can have more of them? I think very strongly you can't start with a recharge rate. That's what we've learned in a lot of other things. In the beginning, you just have to let people come in, use it, and when there's more people using it than we can serve, then you start saying, is this a reasonable recharge rate so that we break even? So we completely agree that the tools are necessary, but not sufficient. And this data is necessary, but not sufficient.
That's a great talk. I was at a conference a few years ago, Futures kind of conference, and they talked about the future of medicine and Watson, and bringing together the cumulative knowledge of the world to a particular patient. How does that kind of bringing the world's literature to bear on these things? How does that fit into your plan?
That's a great question. So the Watson story has kind of evolved a bit over the last couple of years. We've gone from hoping it would solve healthcare. M.B.A. Anderson's sunk $50, $75 million into it. People have lost jobs over it now because the regents of the University of Texas said, wait a second, what happened here? I think some of the promise of things like Watson was way broader than the reality. I think the reality that physicians, nurses, PhDs, social scientists need to somehow think outside academia is very important. And so a big part of this, I've given this talk to FFMI, I'm going to be doing a talk with business development, we're on campus talking, I was at the business school this morning. The concept of partnering with industry to bring industry perspectives to bear in routine healthcare, completely agree with. I don't think any one company is going to be the panacea for that, and certainly no one technique. The literature analysis that IBM Watson did is a really cool concept that I don't think we've implemented. Anybody here gone through that process? So this is the one where they essentially looked through every single paper and said, if you look through all the papers, essentially it was an automated meta-analysis, right? A very cool concept. So I cannot rail against that concept. I don't think we built that into here, but if you have access to PubMed abstracts, you can download that. That's a public available resource. You can actually use this analytical platform. So one of the reasons that we're not focused on just NGI or just human patients is that could be a research project that fundamentally Precision Health helps because all the public PubMed abstracts are freely available. We're building the analytical platform. You can do the natural language processing using the standard algorithms to do the words that John uses at my office about how you break up text into little, and you could actually do that with this platform, and your life would be easier because of this platform than if this platform didn't exist. And so many times, that's how we judge ourselves. Even if we're not giving you the data you want, is your research easier? And it will be with this. But Watson, I'm still figuring out. Larry.
I wonder what you're thinking about some of the communication challenges that might come from some of this precision health data. We're starting some work with, like Roach and I and
Communication.
Scott Roberts, and they've identified some of the communication challenges in the practice of precision oncology, where you'll do this, genomic testing, people will get results back that clinicians don't understand, patients don't understand, and it's actually leading to worry, anxiety, and sometimes inappropriate care. So what's the role for communication in understanding participation and return of results?
I think it's an excellent point. The health implementation work stream is the one that's tasked with figuring that out. I completely agree with you that even today, you don't need precision healthcare to have the communication problem. Every time you have a result that says negative on it, and we convince them that that's a good thing, right? I mean, it's something that's fundamental. Every single negative lab test is a good thing. It's really hard to get a patient to understand that. We're going to create more communication problems. Those communication problems are going to be for both the provider and the patient. And I fundamentally believe that visualizations is the key to that. It's not about giving them another risk score with another probability with a confidence interval. It's about creating pictures that help people understand. The health implementation workstream is designed to help engage with the participants and with the providers to figure out where those challenges are in a very practical, specific way, and then solve them with the basic science of the communication plan. And Scott Roberts is a name that's come up several times with someone we need to engage. Obviously, your name has come up as well. As someone we need to engage when it comes to handling communication challenges. We think the health implementation workstream is the one that's going to help solve that.
Where does medical imaging data fit into this, if at all?
Excellent. I think that's year 2 of the work stream on the core development work stream. So one of the first things we learned from the College of Engineering was when I went and had the conversations with them, they said, it's amazing how many people we have to talk to get to an image at the health system and how we have to redo that every single time. So part of this is going to be having, very importantly, the non-annotated version that doesn't have the layer put on top of the medical record number and the name and all that stuff. So that's not year one, that's year two of being able to access it. The question is, do we actually move that image into a place, or do we just give access to it? Right now the plan is to at least give you a pointer access to it, so you can get to it without having to go through, you wouldn't have to talk to somebody in the Department of Radiology. It's hard enough as someone inside the health system. Imagine if you were outside the health system. So explicitly, unstructured data is year 2 and year 3 of core development. So year 1 is doing more with the structured data we already have. Year 2 is about NLP and images, and waveforms, as you know, is kind of mixed in there as well. But absolutely, I predict it'll be year 2, year 3 for the images by the time we handle the NLP first.
Sachin, thanks for your presentation. Could you say more about the ethnic and geographic diversity of the MGI cohort and what some of the specific plans are to improve that over time?
Yeah, you know, there's good geographic diversity, as it turns out. You know, we've looked at that data set when we were at 36,000. So we just recruited our 50,000th patient 2 or 3 weeks ago. We have a press release upon that. And, you know, that's more than Partners, that's more than Vanderbilt, that's more than Northwestern. All these other people have gotten credit for having these amazing biobanks. It is limited in terms of ethnic diversity very clearly. It is 93% Northern European, just like every other biobank that currently exists out there in the US. 2 specific strategies that are laid out for that. We actually had gone through the IRB process and the contract process for having a relationship with Flint Early Hospital or Beaumont Dearborn, which looks very different than the University of Michigan patient population, as you can imagine. As it turns out, that contract didn't wind up getting funded. That was an NIH submission. Now that these dollars are approved, we're going to be going back to those. We're going to reassess, are those the 2 organizations we should go with? There's a work group designed for that. And if those are the 2 right organizations, we'll be reaching back out to them, and we expect them, once again, an enthusiastic response. That'll be our first foray. I think the next one is going to be about making it a health system free interaction. Why are we using medical care centers to identify our population? So what Gonzalo's done in Genes for Good, it's a Facebook application that just through viral marketing, without a single ad dollar put into it, they have 20,000 people who have filled out all this healthcare survey information and returned a spit kit for DNA extraction. And his are 35% are underrepresented minorities in that data set. And every single state in the United States is included in there. So a direct-to-consumer strategy, just like the NIH is doing with precision medicine, has got to be part of it. But first, we're going to do a healthcare version, and then we're going to do a direct-to-consumer strategy. Excellent. 15 minutes of refreshments. Any other questions?
You mentioned NIH, so there's the All of Us study.
Yes.
How does this relate to that?
Sure. The NIH Precision Medicine Initiative study, which was renamed All of Us, we're very well aware of it. I was on the working group that wrote the report to make the RFP for that, and Gonzalo and I are both involved in the advisory panel, and we get funding through that entity as well. So we're very aware of it. It's an exciting study. The goal is to enroll 1 million participants over the next few years. They've got a similar concept around getting genetic data plus other data, similar concept around underrepresented minorities in there, so their goal is once again 30%. I think what we're going to find is just like a lot of other publicly available data sets, it's going to be an amazing resource that we will want to use. Just like any other national initiative, they were supposed to have recruited 100,000 patients by right now, and we're up to 3,000. I just got the report. Yeah, and it hasn't even launched. They're still in extended beta phase. That is not failure, that is reality. You know, they're doing the right thing. They're making sure that people are being consented the right way. They're making sure the biosampling is correct. When it's done, that 1 million participants will be very interesting. The ability to recontact those participants as a UVM researcher is very limited. The ability to add your data into those participants is non-existent because you won't have access to their identifiers. But just like the UK Biobank, it will be a very exciting hypothesis-generating data set. Probably one step ahead because they'll have more electronic health record data. One of the challenges they've had right now is that 30% of the people enrolling in that study are declining giving access to the electronic health record data. So all they've got is their genotype, a bunch of participant-provided information, and that's it. They don't know their diagnoses, they don't know their meds. So I think our ability to recontact participants, our ability to enrich the data set, and our ability to flex and pick participants of interest will be a differentiator. I hope they succeed. We're going to help them succeed because we think it'll be a nice complement to what we're doing. Just like the Million Veterans Program that the VA's done. These are all things that U of M faculty are involved in and helping build. But we think the more engaged we are with our population, that will be our differentiation. Excellent. Thanks, everybody. Have a good Thursday.